of retrogeniculate pathway pathology, and it's mainly for the PG because most of the neuro-ophthalmologists would be knowing about it. So this is a known hypertensive patient who was referred to us from cardiology department because he lost his vision suddenly in both eyes after the coronary angiography. So when we examined the patient, he had a profound visual loss. He could not make out the difference between the light and the darkness. And on the there was no reflex blinking of the eyes on exposure to the bright light or threatening stimulus, that is Meniere's reflex was absent. The rest of the ophthalmic examination was normal. But after some time, after a few days, the patient started regaining the vision. Now, as we know, this is a case with sudden transient bilateral visual loss after the coronary angiography with normal ocular examination. We know the pathology must be behind the lateral geniculate nucleus because the pupillary fibers, they leave the optic tract before the lateral geniculate nucleus, so they are preserved. That's why the pupillary reaction was normal. And fundus picture would definitely be normal because it was behind the geniculate ganglion, so there is no transsynaptic extension of degeneration to the anterior visual pathway. Then before labeling these type of cases, because we think that the patient has sudden visual loss, such a marked loss, but our ocular examination is normal, the first thing will come in our mind might be a functional visual loss. So confirming that functional visual, these are two pathology in that clinical scenario, these are the two diagnoses which should come our mind. And to now substantiate these diagnoses, the next would be a mirror test and optical kinetic nystagmus. We know in a functional visual loss, patient cannot suppress his movement when you move the mirror in front of him or do the optical kinetic nystagmus. But in our patient didn't show in the movement of the eye on both these tests that confirm that he has really some organic pathology, and that's a cortical visual loss. But patient of ours showed a normal MRI. But the presence of normal MRI doesn't rule out the possibility of cortical visual loss. But this is another MRI of another patient of ours who also presented to us with a profound visual loss, but he didn't recover the vision, and that he resulted into a permanent, he ended up with a permanent visual loss. And you can see that CT of this patient, there is a bilateral cortical infarct, and this is very rare presentation of this case. This is a very rare presentation of a case because bilateral occipital infarct because of the closure of the branches of the posterior cerebral artery is quite a rare phenomena. But this most possibly what happens in these cases, he must have had a occlusion of one of the branch of posterior ciliary artery supplying to the visual cortex quite way back. And that must have resulted into a contralateral homonymous anopia, for about which he was very much unaware or didn't notice that. When he had another attack of occlusion of the posterior cerebral artery territory, which was normal on the previous attack, now he had another attack of embolization into the posterior cerebral artery that resulted into the homonymous anopia on the other side. So the patient now this time interpreted it as sudden bilateral visual loss. Sudden bilateral visual loss most commonly can be seen when there is severe hypotension. And our patient, after a few days, we did the VER, that all was normal. So even that you get the normal MRI, normal VER, do not rule the possibility of cortical visual loss, because the patient can show sometime the normal VER recording, because when you see from our retina, the visual pathways, most of the fiber, they go to lateral geniculate. From lateral geniculate, they go to our visual cortex, the primary visual cortex, V1 area. Some of the fibers, they bypass this primary visual cortex. They go to pulvinar, from pulvinar to the visual association area, V2, V3, V4, V5. Or some of them, they go to the superior colliculus. From there, they go to the visual association areas. So they say sometime these 5 visual fibers, which are in the visual association areas, they may produce the normal VER response in this patient, or sometime this infarct in the visual cortex is a patchy infarct. So there are some neurons which are still functioning, and they may give you a normal response in this patient. So it's very important to know that sometime when you see the visual behavior of the patient is like that, he or she is not seeing, like colliding to the objects around, and the VER and MRI, you get it done, they are normal, then you still think of the possibility he might be having a cortical visual loss, and do the mirror test and OKN test to rule out the functional visual loss. So this is a case of cortical visual loss or impairment, we say, because some of these patients where the insult is transient, they may recover vision. So they say now, rather than calling them a cortical visual loss, call them a cortical visual impairment. And in our case, the cause was a transient spasm of one of the branch of the posterior cerebral artery bilaterally. So a few words about what is a cortical visual loss for the postgraduate. It is caused by lesion of both the sides of optic radiation or to both the sides visual cortex. And it may result into a temporary, depending upon the insult, or it may result into permanent visual loss. The visual loss may last from minutes to days according to etiology, and it should always be bilateral and symmetric. And the visual loss may vary from no light perception to some vision in both the eye. And the patient would not respond when you show a threatening strong light, would not show a reflex blinking of the lids. And this is what I was telling, why the pupillary reaction is normal, because you know they leave the optic thread before the pathway optic tract enters into the lateral geniculate body into pretactal nuclei. So these fibers are preserved, and the pathology in our case of cortical visual loss is either on both the side of these optic radiation or into the primary visual cortex of both the sides. So ocular examination was perfectly normal. VER response, as I told, may or may not be present, but most of the cases it is not present. But some of the cases it may be present. Imaging, most of the cases are normal, shows some pathology. Some cases may be normal. And it's important, like in the children, we get sometimes consultation, a preterm child or a baby is brought into the OPD with a complaint that mother says the child is not fixing, not following, and not showing any visual response. That means in these patients, when we ask them, then we will always find there's a history of perinatal birth asphyxia, and then hypoxia is the commonest cause of the visual loss in this patient. Or sometimes they have a mixed loss. Along with the cortical visual loss, they have an optic atrophy also, depending upon how long the hypoxia period was there. And the pupillary response definitely in children, if we assess, would be normal. And these children, the commonest pathway which is involved, not the visual cortex, in the preterm children is this optic radiation, which presents on imaging as a periventricular leukoencephalopathy, periventricular leukodystrophy. Or if the patient comes very late, then it would be periventricular leukomalacia with a dilatation of the lateral ventricles. So the commonest cause of this cortical visual loss is a hypoxia in the children, ischemia or cardiac or respiratory arrest in the adults, and hypotension is another very common cause, but it has to be quite severe hypotension. A hypertensive crisis or a metabolic cause like hepatic encephalopathy or a status epilepticus, like we know always in the ictus there is a wave of excitation followed by a wave of depression, and that is called ictal emerosis. But these are the transient visual loss in the case of ictal emerosis.